Can you hear
Hello,
me?
Good morning.
Good morning. Welcome to SNU Hospital Cardiovascular Center. I'm H.S. Kim. My colleagues, Dr. Kang Ji-woon, Dr. Yang Han-mo, and Dr. Jang Min-ok over there, and Dr. Ki Yoo-jung. She is an interventionist, but she can do TE analysis. And there are many colleagues around here. From now on, I'd like to introduce our case. Slide, please. Okay. The patient is, next slide, 88 years old male. He felt dizziness 7 years ago. At that time, moderate AS was diagnosed. Recently, he felt chest discomfort. AS aggravated to severe, plus. Among risk factors, there is a very interesting risk factor, chronic renal disease. That is a really important prognosis factor in TAVI cohort. GFR about 50. Clinical presentation is chest discomfort, plus medication and case notes, severe AS symptomatic, TAVI was planned, plus surgical risk score intermediate 4%, plus chest X-ray, ECG, normal conduction, just LVH, plus echocardiograph showed normal contractility, normal wall motion, valve area is 0.5, suspicious of bicuspid aortic valve, plus CT angio shows a tortuous iliofemoral artery and calcification around the aortic arch. We can see horizontal heart with heavy calcification because of bicuspid AS. Thus, I prefer SAPIEN system that can be steerable than Evolut because of horizontal heart. Plus, we can see the fusion of left and right cusp. There's heavy eccentric calcification on non-coronary cusp. Interesting finding is there is no calcification around annulus level or LVOT level. Size is 26 or 25. Plus, sinus valsalva wide enough. ST junction, when I choose SAPIEN, I always focus on ST junction feature. No calcification, good sign. Diameter 33 millimeters, good sign. How about height, plus? Height is also more than 23 or 25. It should be at least more than 22 millimeters. Or triad of ST junction is good for SAPIEN. Height of coronary, good. You can see in the left lower panel, heavy calcification around the non or left, plus. Iliofemoral artery, right. Tortuous but good, more than 6.5, plus. Left, tortuous, but it's okay, 6.5 plus. To summarize the annulus measurement, annulus is about 28. 25 by 31. Thus, when we choose pre-ballooning, we have to choose balloon about 25 millimeters. ST junction measurement, size, good. Height, good. No calcification, good. Plus. Thus, SAPIEN, we can choose 29 or 26 millimeter, SAPIEN 3. When you choose the bigger size, when we meet 10% of our size, we have to do 3 cc on the field. When you choose a small valve 26, 3 cc over field can provide us 9% oversizing. Thus, I'd like to do about 10% oversizing. Thus, we can choose both valve with under or over field. Plus, when you choose Evolut, the annulus morphology is flare, smallest diameter at annulus level. Thus, that size corresponds to Evolut R, 34 millimeter. That is not Evolut Pro, more prone to paravalve leakage, especially in bicuspid AS. Plus, I prepared 3 issues for this case. The first is octogenarian male with intermediate surgical risk. I think this case is really a prototypic indication of TAVI. The other issues are bicuspid. How to select valve type or size? Pre-ballooning is necessary or not? Plus, to select valve type, when we select evolute, we have to do R34 instead of Pro, leakage prone. When we choose SAPIEN 3, we have to pay attention to calcification around the annulus, LVOT, SD junction. No calcification. This junction is tall and wide. Thus, there is at least a chance of aortic damage after TAVI using SAPIEN 3. When we choose SAPIEN 3, which size is preferable? 29 with 3 cc underfill, 26 with 3 cc overfill. For this size selection, we can consider pre-ballooning plus. Good thing is, it is helpful for appropriate size selection, but trade-off is it increases stroke risk, especially in bicuspid TAVI. Plus, because this is the case presentation, and we can show the angiogram that we taken several minutes ago. Angio, please. Okay, we always puncture the common femoral artery under the fluoroscopic guidance. Plus, then we introduce sheaths. Plus, then we take baseline root arterography. The best angle is just caudal 5. We can see severe calcification, especially on non-coronary cusp. We are concerned about calcific shadow on the left coronary cusp. That is a little below the annulus plane. That may lead to leakage, but that may not be associated with annulus tear because the direction of calcium is a little bit low direction, not horizontal direction. Plus, then we introduced wire and passed aortic valve into LV. Dr. Kang Jun has some interesting habit. He just tried 3 times of insertion of shaped wire before remove it and change to straight wire. He tried 30 times, but today he was successful in introducing curved wire like this. Plus, then we measured the double tracing, LV and aorta. Can you see the, okay. As you can see, the left lower panel, there is a huge pressure gradient between LV and aorta. This is the step that we have taken this morning. Is there any comment, question?
Yeah, any comment, Gorobe?
Well, good morning. You are stunningly well prepared for this live case, giving us a lot of headaches here. I think this is a very interesting case under all the aspects, that you summarized. And be it a SAPIEN or an evolute, can you tell me again, because I might have overlooked it, what the perimeter is? Was it 85?
Wait a minute, slide please.
Well, the perimeter 85, right?
Perimeter 88
So
or 85, okay.
85, right?
Slide,
Yeah.
slide, please.
So
Please.
my primary concern here is not so much bicuspid. I would probably predilate with a small balloon because it's bicuspid and you can see how the leaflets are moving. The coronary height, I don't think are an issue because there's still a little bit of sinus. So I don't think that this is a problem. Interesting is your choice of valve. I'm assuming you're taking the sapien, either you underfill or overfill, because you consider this to be horizontal aorta, and then short valves are always easier to be deployed. My concern is just a lot of calcifications, and that's why I would be very careful to oversize and to be too aggressive over in a balloon expandable valve situation. If Lotus was available, I don't know whether it's available in Korea yet, but this would be, for me, this would be a good case for Lotus actually. But since this is not an option, now we're dealing with the Sapien or the Evolute. Probably I would not take a 34, I would probably take a 29 Pro, but if I take the core valve, but I'm assuming you're taking the Sapien, right?
Yeah.
Yeah.
Thus, regarding the Lotus Edge system, I prefer Lotus Edge for these patients, but Boston Scientific cannot provide Lotus Edge at this moment. In South Korea, I experienced one case of Lotus Edge last month, but there is shortage of proctor around the world, thus they cannot provide proctor. So I can do Lotus Edge by myself. They agree with me because I was a proctor of traditional Lotus system, but my colleagues are not accustomed to Lotus. Thus they insist me, we have to undergo 5 cases on the proctor. Thus we just finished one case of Lotus Edge on the proctor, thus I was not able to prepare Lotus Edge system for live demonstration.
Yeah.
Okay.
Anyway.
Okay, you recommend a little bit smaller size of valve. So when we choose 26 millimeter Sapien 3, we first consider 2.5 cc overfill to meet 7% oversizing. Then if there is a leakage, we can repeat ballooning up to 3 cc overfill to meet 9% oversizing. In any way, we just do a pre-ballooning with dye injection and see there is leakage or the pre-ballooning is very tight. If very tight, we choose smaller valve. If it is dye is leaked, the annulus is bigger than we expected, we can choose 29 Sapien 3.
Okay, sounds good. Any other comments from the panels?
Rick?
Or any other-
Hi, Dr. Kim. It's Eric Finkelstein. How are you?
Hi, how are you?
I'm good. I think you made a good choice for completely different reason, and this is the very calcified aortic arch. And I think that the main advantage of Edwards in this case is the flexibility of the delivery system, which is in your case very important. Otherwise, I'll just do whatever Eberhard just mentioned. If it would be Evolute, I would take the smaller one, the 29th, because it's heavily calcified bicuspid. And I think you took the right one, the 26 plus 2 cc, but the final decision will be after the balloon predilatation and injection. And you should take care of the coronaries because as far as I saw from the angio, you have a lot of calcium on the leaflets that can block the annulus with all due respect. So have a good luck and I trust you.
Okay, thank
Okay.
you very much for your encouragement.
Okay, please proceed your case.
Yeah. Okay. Then we just continue without interruption until the valve implantation. Okay. Balloon, 25 millimeter balloon.
Maybe they cannot find the two luminous.
Okay, 잡았어요. Okay.
So you're pre-dilating with what balloon size?
25. The shortest diameter of the annulus.
So how do you decide the sizing of pre-balloon?
The shortest diameter of annulus. Diameter of annulus is 25 by 35. Thus we select 25. Okay. 자, 들어갑니다. No resistance.
Just for curiosity, Arik, would you, if you take an evolute, would you
Just
actually
test.
pre-dilate with 25, or would you just take either a smaller balloon or not pre-dilate at all?
Rapid pacing.
I would definitely pre-dilate
Shoot.
with injection, and I won't take a smaller balloon than that. I'll take
Inflation.
25 at least, yes.
Okay. Size, position is good. Okay. Rapid pacing. Inflation. Die shoot. Deflation. Pacing off.
Now take a good look at the piece of calcium, the way it moves like
Minus-
a door towards the ostium of the left main. Now, this is three-dimensional, so you cannot
Okay,
assume
stop.
anything, but you can
자,
understand
minus-
that there is a risk of coronary
T.
occlusion.
혈압 낮네요.
Have a look at this piece of calcium.
T 보여줘야지. 유학생 오케이, 자 빼고. We expect there is some kind of hemodynamic compromise if we perform a ballooning. Thus, okay, prepare, valve, ready? Okay. 26. 26. It's no leakage.
Yeah, this is the post-balloon echo.
Do you prepare? Or do you already prepare 29? Okay. How about the echo?
Looks very
No
good.
second leakage.
Yes, the second. Before ballooning, the severity of the PVA was trivial. After the ballooning, the severity of the PVA was mild PVA.
테르모.
Looks like a very good valvuloplasty.
They already prepared a 29 millimeter valve without seeing the result of the pre-ballooning. So they did not
29.
listen our discussion.
Well, I mean, that's the question with bicuspid valves. You know, with that amount of calcification, you can see that with a 25 balloon, that was already fairly aggressive.
Yes.
If you take a 29, I think my understanding is that you underfill, right?
Yeah. How is the limit of underfill? We just consider 3 cc underfill. Can you do 3.5 cc underfill? Okay. They already prepared a 29 millimeter valve. Thus, we have to do 29 millimeter valve. Okay.
So
With,
what's your plan? 3 cc on the
Is it
field?
possible 3.5 cc on the field? Yeah, 3.5 cc on the field to increase the safety. How about the movement of calcium chunk? Sinus valve surface space is large enough to accommodate displaced calcium chunk. But
But
in non-coronary size, the sinus valsalva is all occupied by displaced calcified leaflet.
Yeah, that's what I said before, and I got to admit that, well, in those cases, despite of what we all talked before, I think that there is advantage for self-expandable retrievable valve.
혈압 좀 낮네.
And coronary protection, preemptive coronary protection is pretty necessary in this case.
I think this is an interesting case. I mean, obviously, Dr. Kim is very experienced, and it's his decision and his choice. It would be interesting to see what the panel is thinking, what kind of valve and what size of valve, because this is really a very difficult TAVI case, given the amount of calcifications, the chunk, it's not circular, and the size, bicuspid. I'm not sure whether I would follow the in this case the SAPIEN approach, but obviously we will see. I would just be afraid. You can see that the calcification moved into the sinuses,
Yeah.
and did not affect the left main.
Ariel, do you have a concern about coronary obstruction?
Well, yes, I am concerned, but I haven't seen the CT analysis, and the CT can tell you exactly before the procedure whether those pieces of calcium that in the angio we see it two-dimensional. In the CT you have the ability today and to predict whether they are going in front of the coronaries or not, which I cannot tell right now. But you can see that even that the sinuses are not very small, the chunk of calcium is almost obliterating it. So if it is in front of the coronaries, it is dangerous.
Yeah, the good thing is main calcium chunk on the NCC cusp. Thus, I think such a big calcium chunk on NCC cannot obliterate the RCC, right coronary artery. Even though we see there is overlap between non-coronary sinus and RCA, but actually the dimension may be different. And RCA height is about 12 millimeters. Okay, please pray for me and patient.
Mainly the patient, okay?
No.
So for the bicuspid AS, which valve do you prefer, Dr. Grube and Dr. Nandola?
It's the best angle.
Well, first of all, I don't want to comment while he's doing the case, because it's a very difficult, for me it's a very difficult decision in this situation, which valve, both valves have advantages and disadvantages in this situation. Obviously, it's what you feel comfortable with. What I would have done, though, is I would have not taken a 29. I tend to undersize in bicuspid calcification situations, both for SAPIEN and for. But let's see. We pray, so it's okay.
Test it. Okay.
I would definitely not go too high. It's underfilled with how many cc's?
3.5 cc.
I see.
The maximum he can.
Test it. Okay. Then I will do implantation. 자, pacing on. Die. Inflation.
Inflation, half inflated,
Two.
full,
1, 2, 3, 4, 5. Depletion. Pacing off.
Position is very nice, Dr. Kim.
빼고. Thank you.
What was he saying? Tradition.
맞추고. 자, 바로 들어갈게요.
The heart's still beating, that's a good sign.
맞춰주고. 자, 시내 갈게요, 바로.
No, he is recovering.
Shoot. 다리를 좀 올리고. How about RCA flow? Stay, okay, good. How about aortic tear? At the junction, good. And then let's dial a little bit 올려서.
Looks fine.
Looks fine.
Yeah.
So T,
You know, it's a very weird phenomena. I don't know if you all notice it. The recovery of the blood pressure after the implantation of Edwards takes much more time than the self-expandable. And I never, ever, even if you are rapid pacing while you are implanting the self-expandable, the recovery takes more time with the Edwards. I don't know why. Not too much, okay, but it takes more time.
Looks
can you
good
see
though.
the T? So longitudinal view, we cannot see a significant leakage because oversizing index is about 8%. Short axis view. Color. So no probable leakage. So I think always oversizing index is very important. Bigger, less leakage, in spite of higher risk of complication tear.
Dr. Kim, can you show us the hemodynamics with the pigtail in the ventricle and the aorta simultaneously? It's extremely important here.
Okay, I confirm there is no leakage. So I just changed the stiff wire because there is no underexpansion of valve frame. 알아요? Different angle. So I already checked the angle, caudal. If there is remaining valve frame distortion, no. Left 쪽. If there is a residual valve frame under expansion, I always do post-ballooning. But in this case, oversizing this is a little bit big, thus I skip the post-ballooning. And I exchange the stiff wire into pigtail for the double tracing. AP 준비되고요. 자, wire stay. 베스트 앵글 주면 되겠네. wire. wire. 오케이. pigtail.
The T finding looks very good.
Yes. So I always concerned about hematoma formation, pericardium, or dissection of root. But still, until now, there is no complication. So please confirm it again. 가만히 있어요. 자, 아래요. 오케이. 자, 제로. T 보여주고. 그다음 엔조 플러스 보여주고.
There is no pericardial effusion.
좌하기에 T 보여줘야지. 이학 선생.
Tracing, please.
pressure. 이학성 선생 pressure. 그 트랜지션이 늦어 이학성 선생. 오케이. 헤모다이내믹스 스케일을 좀 바꿔주고. So we can see the pulse pressure is narrow, suggesting no leakage.
Very nice.
Definitely.
Just please calculate AR index. LVTP 20, diastolic pressure about 45, systolic pressure about 85.
I
85.
I think they have a perfect
Systolic
result.
85. 아무도 도와주지 않네.
Very
제가
good.
영어를 못 알아듣네. 네.
Very,
84,
very good results,
85.
Dr. Kim. Congratulations. Can you see the TE?
Okay, TE, please. 이학 선생 TE로 컨버전 해줘야지. 이학승 선생 TE로 컨버전. 기사가 지금 유능한 기사가 아닌 모양입니다. 죄송합니다. 조금만 기다려주세요.
인슈렉스
TE를 가르쳐 달라 했는데 또 엔조를 띄우고.
There is no PVL in Zurich view.
오케이, 타이로 익스체인지 할게요.
Dr. Kim, I have a question. I mean, the results are beautiful, very successful. We congratulate you. But there is one question I don't understand, one issue I don't understand. Why is the patient in general anesthesia with a TE? Is this your common practice, or is it because it's a live case, or is there any other
There are
reason?
two
for that?
reasons. Live case, you always request more precise information with good quality of image. Thus, TTE, TE, totally different. In this case, very complicated. There is a high risk of complication. Thus, real-time monitoring with TEE is really required.
Okay.
Okay, then
Thank you.
air index is about 32. Thus, I show you removal of ventricular catheter.
Okay,
Okay,
Dr. Kim, I think Dr. Kwon is waiting
Best then.
to show us the result of his case.
Okay, I can show you final 3 shots.
Okay.
Okay.
We will
That's
stay with
all.
you for the final 3 shots. And
Okay, I always do 3 projections. Okay, good. Sine? Okay, AP injury.
Very nice.
I always
good.
pay attention to SD junction tear and leakage of dye around annulus. Caudal. Okay, second shot. Okay, third shot left. 약간 cranial. Okay. So I always pay attention to the underexpanded valve frame. We can see a little bit distortion in left side of valve frame, but as you recommended, it is too aggressive already.
Yeah,
That's
you're not going to be
afraid.
greedy, right?
So,
Dr. Kim,
so one very last question. Because the patient has renal insufficiency, wouldn't it be adequate to just, if you're very happy with the echo, to leave the angio
Okay.
alone and don't overload with more contrast?
It's good point. Usually we do not aggressive angiography. For this live case, we perform angio more aggressively. Then we always have a plan to remove the dye as soon as possible after procedure. Before procedure, there is a limitation of volume overload. Thus, in this case, in such kind of TAVI case, we always very aggressive, including CRRT to remove the dye to protect kidney.
okay, Dr.
Very
Kim,
good.
congratulations on your perfect result. I think the patient is going to live until he is 100.
Okay.
So let's move to the case at Samsung.